said, my name's Coralie. I'm a physio from Queen Square, so the National Hospital for Neurology and Neurosurgery. So I know you've spoken to with my colleagues before. So in the past, I've worked quite closely with Henry in the orthotics department. And last year you heard from Geeta. So I've got some caveats really before I start to talk. I'm not a specialist falls practitioner. That's not what I do. But I think you would be very hard pushed to find a falls practitioner that specialises in neurology, let alone in HSP. But what I do specialise in is helping people with walking difficulties in the area of FES and orthotics. And usually one of the big reasons that they come to see us is people come to see us is because they are falling. And I'm also not a researcher, so like Henry and Geeta are at the forefront of all the developments in HSP. I'm not predominantly a researcher, but I'm on the ground working with patients, and hopefully I can help you in that kind of more pragmatic point of view. And now my slides won't go. Okay, here we are. So I'm just going to give a brief outline about falls today, and then think about some general risk factors for falls, and then anything specific to HSP, and then really just to give you all some food for thought about what you might do to manage your own personal risk of falling and having injuries, and how to manage a fall when it might happen. So a bit of stats. I mean, most of the research and information about falls that is out there is predominantly about people who are elderly. So we know that it's a common risk or cause of injury in people that are over 65, and that people that are over 80 fall a great deal. It won't surprise you that people with neurological conditions are twice as likely to fall. So if you match the age of kind of healthy or people with no neurological condition with someone with a neurological condition, they're twice as likely to fall. But that doesn't give you a personal kind of risk factor for yourself. And often in these studies with neurological patients, they don't include anyone with HSP either. So they're predominantly people with Parkinson's disease or stroke or MS. But yeah, you guys, HSP is a little bit more unique and not often in there. It is a big problem. So falls can be catastrophic for people. So it actually is worth paying attention to them, and can cause death. And worldwide, that is a big problem. And that's why it gets talked about a lot, particularly with people that are elderly, because it causes a great deal of burden on the healthcare system. And of course, if you have a serious fall, this is from the CSP kind of falls presentation that was done a couple of years ago, and they do an education week on falls every year, I think. But essentially, if you do fall and it's a serious fall, it leads to a bit of a downward spiral. And I don't know if anyone here has kind of experienced that before, but often that will then lead to people becoming fearful of falling, their strength and their balance reduces, and then people become less active, and then they lead to more falls. So often just having one bad fall can actually lead to kind of quite a deterioration in your condition. So it's not just the injury that you sustain from that one fall, it's also kind of on from that kind of the secondary impact, I suppose. But what is a fall? It's interesting really, because we talk to people in clinic and ask them, one of our questions always is, do you fall? When was your last fall? And actually, when you look at the definition, it's usually about kind of hitting the deck, if you like, so actually kind of falling all the way to the ground. But I think that's not necessarily what your clinician or need to hear about, because actually that's kind of the worst outcome, hitting the deck. But what we find, people are having a lot of near misses, and luck might be on their side in that they manage to catch themselves on a wall or a bit of furniture, or someone's nearby to hang on to. But I think those things matter quite a lot as well. So you know, falls aren't, I think, from a clinical point of view, just going down to the floor, even though the definition might be that. It's also quite normal to fall, depending on the circumstances. So as children learn to walk, they fall. That's part of the learning process. In sports, people fall. So actually kind of considering for yourself the circumstances of falls and what may be an acceptable and an unacceptable fall. So in there's kind of a handbook of neurology, there's a chapter about falls, and it's quite a nicely written chapter about falls because it's really pragmatic. But essentially they try to classify what is an acceptable fall, what's okay, what are we not worried about, and which kind of falls are we worried about. But essentially the acceptable ones are the ones that you don't hurt yourself and you don't hit your head. People, when we talk about falls, we're always very concerned about people hitting their heads, because obviously that has the most risk of serious injury. And then also, if you're not in a vulnerable population, so you don't have any disease or any risk factors from that point of view. And also, if the fall occurs just because, you know, you've pushed yourself, you're doing a sport, you've pushed your balance on purpose. You know, we're watching the Olympics at the minute, and there's plenty of falls to see there. And they're all kind of totally acceptable falls, really. But where they are more unacceptable is if you're in a vulnerable population. So I would argue that if you have HSP, you are more vulnerable. And if that fall is happening just in your daily routine, so doing things that should be totally within the realms of normal function, normal balance, etc. So with regards to kind of the risk factors for falling, they're quite generic. So this is kind of the, oh, my animation's not working, there it is. These are quite generic risk factors. So they're not specific to having HSP, but they are really worth considering, because if there are any of these areas that apply to you, if you can make a change to them, influence them, consider them, and optimize them, it might kind of, you know, help with just a little bit of incremental gain, if you like, so you're not as much at risk of falling. So the major risk factors are, we've talked about already. If you're older, we know that older people fall more, so over 65 and then over 80 for that greater risk of fall. And then if you have any impairment to your walking pattern, so imagine for those of you that are mobile and walking, whether that just be walking indoors or walking longer distances, if there's any impairment to your walking, it's worth considering what things can be influenced and changed to reduce your risk of falling. Also, any chronic conditions can increase your risk of falling. So HSP would be a chronic condition, but if you have anything else alongside your HSP, and making sure that's kind of managed as best as possible. And that can include things like arthritis and pain that's associated with that, or any problems with continence, or any polyneuropathy that you might get from diabetes. So it could be a great number of conditions, but all of those things can influence your risk of falling. Any reduced muscle strength, so people that are weaker are more at risk of falls. So optimizing your strength is really super important. And impaired balance, again, we know that balance is all is influenced by your strength and your walking pattern, but again, that's something that you can focus on to see if that can be influenced or changed at all. Also, we've kind of talked about the downward cycle before, but if you've had falls or previous falls and you develop a fear of falling, that also increases your risk of falling again. Any problems with dizziness at all? So one reason you could be dizzy is if you have any postural hypertension. So that's when you stand up and you become lightheaded because your blood pressure might drop a little bit. So if you ever experience symptoms like that, there are things that you can do to ensure that you minimize the risk of getting dizzy and kind of losing your balance and orientation. And that includes just being really slow and making sure you're steadying yourself and making sure you're really hydrated. And of course, if it is a significant problem, you should really see your GP to make sure there's no blood pressure issues that can kind of influence that. Oh, I don't know which one came up. Here. Hold on, here we go. Again, so I put a picture of an ear for that one, but inner ear problems and vestibular problems can also cause dizziness and imbalance as well. So if you're noticing any problems with that, also speak to your GP or your physio. Who came up there? Your vision is super important, that you can see and that you're wearing the right glasses when you're up and about. So if you do need glasses, wear them and make sure your prescription is up to date, but also consider if you should be using wearing bifocals when you get up, and they can increase your risk of falls and things as well. Any foot problems at all? So obviously sometimes there's changes in your foot posture with HSP, with weakness and changes in alignment, but there may be simple things like corns on your feet that are painful, toenails, anything like that, but also making sure you're wearing appropriate footwear when you're getting up. So I mean, I'll talk a little bit more about footwear because that's super important in minimizing your risk of falls too, but worth thinking about your list, on your list. The next thing is polypharmacy. So that means if you're on lots of different medications, it can increase your risk of falls, and there are particular medications that put you more risk of falls, particularly things like benzodiazepines can make you more at risk of falls, some types of antidepressants and antipsychotic medications as well. So if you feel like you're on a lot of medications and you're not sure what all of those do and how those influence your risk of falling, it's worth having a review of your medication, either with your GP or your consultant, or even your practice nurse or falls practitioner. And the last one on the list is, this could make anyone fall, but alcohol does increase your risk of falls, unsurprisingly. But if you pair that with having a chronic condition, some gait disturbances, some foot problems, some, you know, like if you put all those factors together, it increases your risk of falls even further. So it's kind of considering all those tiny little things that you can influence and change and optimize as much as possible to kind of minimize your risk of falling, if you like. So these are kind of the risk factors that are kind of within yourself, if you like, but there are lots of kind of external factors kind of at home or in your environment that you can influence to help kind of manage your risk of falling as well. One thing is the lighting. So it might sound unusual, but if it's particularly dark when you get up, or there's a real glare because you've got really bright lights that aren't shaded properly. That can really disturb your orientation and your balance and leads to a risk of fall. So my mum had a really bad fall about a year ago, and there were kind of a couple of extrinsic factors, and one of them was lighting, actually, and we got her like a smart light bulb for getting up to the loo in the night. So there are little kind of things that you can make so she, you know, says okay Google and it turns on the light, and then she's safe to get to the loo rather than tripping over. So little things like that can make a big difference to your safety. If you're like me, there's lots of obstacles at home. My obstacles are small people and small people that leave stuff everywhere. So if you've got kids and grandkids that are a forever moving target, that will definitely increase your risk of falls. But also you may need to think about other obstacles in your home. One of the things that I'm getting to see a little bit more now we're doing virtual clinics is inside people's houses, because I'm usually clinic based, and there are lots of environments that we can talk about and improve. There's wires over the place, there's a spare heater, there's a rug, there's a pile of books. And although you may feel that you know your way around your house, so they won't be a hazard, if you do get caught off balance and it is there in the way, it could trip you up or cause you to have a worse fall than if it wasn't there. So do think about kind of obstacles and hazards. The surface that you're walking on obviously will have impact as well. So if you're choosing new flooring, obviously you can think about what you walk best on. And sometimes you can't choose your flooring because it's in your house or you're going out somewhere. So then you might need to consider what would make you safer. So that might be using walking aids or different footwear that's more grippy to make sure you don't slip. Or you might not want to go walking in particularly icy conditions and things like that as well. So we kind of said about foot problems, and I touched on footwear too, but footwear has a huge impact on our walking biomechanics and our safety. So I would advise against, in general, slingbacks, flip-flops, and anything that's unstable. Make sure you do your shoelaces up, make sure your shoes are on properly, but also consider things like your clothing. So things that are really trailing that might trip you up, really long trousers, or skirts can get you in a tangle. And whilst they might feel okay, sometimes if you do lose your balance, it could be the one thing that kind of completely sends you off balance. Put a picture of a kitchen here, and ergonomics is something really interesting to consider in your own home to minimize your risk of fall. So years ago, I went to a really interesting talk about someone who specializes in falls in Parkinson's disease. But I think this is really applicable. But they did a study where they mapped in different kitchens how many journeys and how many turns you have to do to make a cup of tea. So, and you can map that in your own kitchen, make a cup of tea, make your breakfast, whatever it is. But actually, just by reconsidering where the tea bags are in relation to the kettle, in relation to the milk, could actually really minimize the number of turns or corners or journeys you have to do up and down. And it's those kind of movements that, when your balance and your walking is more difficult, that could put you at risk of tripping up and falling. So have a look at that in your own home. And then lastly, kind of use of inappropriate walking aids can actually be a trip hazard as well. So make sure that whatever you're prescribed or have been prescribed in the past is actually appropriate and is not going to trip you up, that it's not adding an extra hazard to your day, and that actually, if you're not using it, it automatically becomes a hazard because it's hanging out in your house. and it's something else to trip up over. So clear out the stuff that's not helpful, and if you've tried it, you've been advised it, and you've tried it and it doesn't work, just get rid of it rather than having it around the house and something else to catch your feet on. So the considerations that are more specific to HSP are really around the gait pattern and balance. And I don't want to kind of go through everything that Geeta went through kind of similar last week, but we know that in HSP, when you're walking, there are some typical walking patterns or alterations to your walking pattern, which may mean that your feet kind of a bit more inverted, so turn in a little bit. They might catch the back of your heels. Your knees might snap back, make kind of jolt a little bit when you're walking. All of those things can make it can increase your risk of falls, because you're increasing the risk that you will catch your feet or become unbalanced. We know that there is some weakness in HSP as well, particularly in the kind of around the hips and the dorsiflexors. However, what I would say is when we see people in clinic, so a clinical picture, when we do formal testing lying down or sitting in the chair, often in a lot of cases, people's strength is really well preserved, but what we see is that the timing is really altered. So even though the strength might feel like it's there, it's just getting those muscles to kick in exactly the right point when you're, in a functional activity that's really quick. There's also kind of some muscle stiffness, passive stiffness for some people, and that can cause some imbalance around the joints. And some people end up having some changes to kind of bony changes, so changes to the alignment of the feet, around the back and the pelvis as well, all of which changes your balance and your center of balance. Some people, not all, I mean, this will be depending on your condition, will have some sensory changes. So the information that you're getting from the floor through your feet and through your skin. Or most people with neurological conditions also suffer with an element of fatigue. So and I think that is true from what our HSP patients tell us as well. And consideration of planning your day and where you use your energy is really important to also manage your risk of falls rather than going for a boom and bust approach. So you've got to kind of decide where your energy goes and what the priority is to use that energy and make sure you're safe. And I know some people can have some problems with their bladder, and obviously if you need to get to the toilet urgently, that will increase your risk of falls, and particularly using the loo at night. So making sure that you can kind of do that safely, as we've kind of talked about lighting and things as well with regards to that. And then a lot of people find that in neurological conditions, and again, this isn't specific research in HSP because you guys probably all know that there's less research in HSP compared to some other conditions, but we find that people have reduced capacity for dual tasking. And basically what that means is where it's really difficult to concentrate on two things at once. So for you, the concentration when you're walking or mobilizing or doing a functional activity will be on that activity or walking. But if you try to text on your phone or scroll through the news on your phone at the same time, or talk to a friend that you're with, that's when your balance will become even more impaired. So there's a real risk with dual tasking. So often we kind of try to get people to focus on walking when they're walking, and when you want to talk, like take a break, sit down, have a chat, have a coffee, and try not to do them at the same time. Easier said than done, I know. But. So I wanted to talk to you a little bit about kind of aids and adjuncts and things, kind of what I specialise in. But I suppose what we find is that people find it really difficult to come to a point where they accept adjuncts and aids. So we're very aware of the visibility and the practicalities of them. But what I would say is that you need to kind of think about introducing them before the fall comes, if you can. So if you're noticing that you're at risk, and you're having wobbles, more stumbles and imbalances, that you kind of think about what aids and adjuncts would be acceptable to you before you have that catastrophic fall. I know that's not easy to do. We hear that a lot from patients, but I wouldn't be doing my job if I didn't encourage you to kind of think of that before something happens. So something I do a lot of is orthotics. Now, Adam said you guys have heard a lot about FES, not so much about orthotics, but orthotics are basically external splints or aids that might kind of help you pick your feet up or stabilize joints, there's a huge range. So I'm going to just show you a few different things so you get an idea of that. So this is like a really long list of what orthotics might help with, but basically they can both help with stability elements of walking, so making your leg more stable when you stand or when you're on a standing leg, but they can also help pick the leg up. FES is less good at that. That just does the picking up bit, whereas orthotics can do a bit of both. And you can get prefabricated orthotics. So basically that means your physio or orthotist will go to a cupboard and just get one straight off the shelf. And they're usually lighter, sportier looking, but they're really accessible. They're something you can try and see if this is a route that you want to go down. It's a nice introduction to orthotics, essentially. But they're not so good for people that have changes in their anatomy. So they're kind of, designed for an average foot, an average leg, and the rest of it. But I'll show you a couple of things in the next one. And then the next thing is a custom-made device. So the next step of buying something off Amazon or out of the cupboard with the orthotist is a custom-made device. So that will often be much more rigid. It will be cast to your leg and your foot so that it's exactly the shape of you. And then it can be molded, and it gives much more control to the ankle, to the foot. There are pros and cons to all of these things, of course. And something you might not think about so much with orthotics, because it kind of sits under lots of different areas, is insoles, or FFOs, means functional foot orthoses. So it's a posh word for insoles, essentially. But there's two pictures of feet on my screen. The top screen is what we would call pronation, or kind of flat feet, if you like, where the feet roll inwards and there's the loss of the arches. So you can have insoles to help support if your feet kind of go in this posture. And in the bottom photo, you can see the foot on the right hand side is more supinated. So we might see that more with people that have HSP, that the foot kind of turns inwards, or you end up on the outside edge of your foot or just on the ball of your foot. And there's some really simple, quick like aids for that. And actually sometimes it's as simple as just using a heel raise in the back of your shoe to accommodate any shortening. But you can also have insoles made by an orthotist to kind of support the shape of your foot. And this is probably the most discreet thing, because you just pop it in your shoe and it can give you a bit more of a stable base. Your footwear that you use for walking or in combination with orthotics is essential to your walking biomechanics. So we spend a lot of time talking to patients about footwear. So kind of you don't have to buy extra special shoes. Usually what you're looking for is a bit like this pink running shoe is kind of an ideal type of shoe to optimize walking, but it has a nice heel pitch. So there is a wedge at the back of the shoe, and then it gets slightly narrower under the ball of the foot, and it has what we call a toe spring at the front, which can help you roll forwards on your foot. So you've got some very a very simple thing you can do just to help your walking biomechanics by accommodating your heel and helping roll your foot forwards as well. So picking the right shoe. Some people find that they can use high tops or boots, a bit like orthotics as too. And if you choose the right shoe, that it can kind of do the job of using a sporty kind of prefabricated splint. So some people we see will always wear really high boots just to help there. But you can also have your normal shoes adapted to help you too. So this pair of shoes in the middle has a bit of a funny looking shoe on the right hand side. So it's got a heel raise that's been put on the outside of the shoe, and it's also got a wedge on the side of it as well, just to tilt the foot in the right direction. So as well as the insoles that go inside, you can also have adaptations on the outside of your shoe. So you can either have a heel raise or a wedge at the back to turn the foot from the heel. But you can also have a float on the side of the shoe, which is a bit like a kickstand, if you like. So it flares out from the last of the shoe and then outwards, and can make you feel more stable. It's pretty rare for us to do custom-made shoes these days, because you can put all of those little things on top of your preferred footwear, if you like. So these are kind of some of the ideas of some the prefab or like off the shelf splints. So these are kind of neoprene and stretchy and supportive. They're a bit more sporty looking. I think one of them, the pusher queer, I think Andy Murray was wearing when he injured his ankle. So you can kind of get away with saying, you know, it's your tennis injury or whatever. But there are ones that attach to your shoelace like this and can help pull the foot up, but they're the least supportive on the spectrum of orthotics, but they're a good kind of entry point, and they are lightweight and more discreet, I think, in general. The next step up there is, this is called an AFO, ankle foot orthosis. So this is plastic. It's still a lightweight plastic. It still comes out of the cupboard, pre-made, but it will help lift the foot up. But if you've got any changes to how much flexibility you have in your calf, or any changes in your foot posture, it won't be particularly well accommodated in something like that. And over the last 10 years or so, we're using a lot more carbon fiber in orthotics. I don't know if anyone's seen anything like this, but they remind me a bit of the kind of things that you'll see in the Paralympics, you know, with the prosthetics. So they're carbon, and they have basically some energy return to them as well. So you get some spring that can help you kind of lift your leg through. They're very lightweight, but they are dependent on you having enough flexibility in the ankle. So that's super important. And they're quite rigid. So for some people, it's too rigid to cope with. It doesn't have enough flex in them to be able to kind of to cope with them. And then kind of the last thing on the list is a custom-made plastic AFO. So this is when something's completely molded to your leg, and it's pretty rigid, and people will say it can feel quite heavy. I mean, if you speak to an orthotist who makes these, he would say, or she would say, they are not heavy when you walk correctly in them. You won't feel the weight. But I think for any patient presented with those, they're often kind of taken aback that looks like quite a heavy thing to have on my leg. I would say that we've had quite a lot of success using these with people when their condition progresses to a point where they really need that stability to be able to stand, to transfer, to do a few steps, but maybe not dynamic enough for people that are much more mobile. But I mean, it's very personal and individual basis. But essentially what an AFO can do is, this is kind of a leg on the left where your hip might be very flexed and your bottom kind of pushes out, and your knee is hyperextended. So it means kind of locked back or pushed back. When you put an AFO on, essentially it's ridded, so it helps keep your shin bone more vertical, so prevents the knee from being pushed back, and that can align your hip as well. So there's much more play with biomechanics with that. So whereas some of the other devices, they won't really help with your knee, this one is preferred. If your knee really snaps back, it can help kind of control that as well. But you know, there's pros and cons to everything. I think one of the big things to highlight is depends how much you're doing stairs and getting on and off the floor and bending down, how much rigidity you can cope with, essentially. And there is no one size fits all at all. So you guys know, I think, a bit about FES, but that essentially is an electronical drop foot stimulator. So you can use electricity to stimulate the nerve that picks up your foot when you're walking, and we time that. There's different devices out there on the market. At Queen Square, we use kind of the odd stock equipment because it's more cost effective, but there are kind of more fancy wireless ones. But essentially, they use a heel switch or pressure sensor to trigger with your walking. And this Bioness and the Walk Aid, they're a bit more fancy and they don't need heel switches. They use a accelerometer and a inclinometer, so they know exactly where your leg is in space when to trigger. But they essentially all do the same thing. So this is really nice for kind of realigning feet. So but it does not give you any support when you're standing on the leg. It switches off. So this is all about clearing the feet. So if your feet are catching each other or catching the ground, it will help kind of swing those through. But once your foot is back down on the ground, you lose all of that support. So that's where the orthotics can help more. We do a lot of 2-channel stimulation with people with HSP because they tend to have problems affecting both of the feet. And often we find if we correct one foot, we make people very asymmetrical and it's quite difficult to cope with. We use the most regular kind of setup we use is for bilateral drop foot, but you can put electrodes anywhere, essentially. So some people will use it on their hip flexors to help lift the leg, or behind the knee to stop it, to help with clearance more there, kind of bend the knee and lift it up. But, you know, it is more to cope with if you've got electrodes that are in funny places on your bottom, you know, or on the back of your leg, getting to the loo and wires and things. It can be quite an undertaking for some people, but really effective, I think, for others. But it's something worth considering. It's not just drop foot. You can kind of look at other applications as well. But we see with patients that it does stop patients trip and fall, and because it stops the foot from catching and it helps the clearance. And then for some people, it helps them walk for a little bit further, a bit more efficiently. What we do find, particularly in HSP, but across the board with FES, is that that the benefits are not always directly correlated with objective change. So what I mean by that is a lot of our patients will come in and the FES will make them walk slower. It won't instantly change their walking speed. But when they go away and they're in function, they're reporting that it makes them feel much more confident, that it makes them feel like they're able to do more. But, you know, if we test them, you know, in a lab with their walking speed, they're not necessarily going to be any better. And often it does slow people down, I think, with HSP as well, I would say. But you know, if you're starting to consider what would be best for you to stop the tripping, the FES or the splints, it will be really personal. The FES takes more time to set up. And some people don't like the sensation at all and they find it quite fiddly. But it does give you a little bit more flexibility with your footwear, and also can give you a bit more flexibility with the effect that you get, a bit more dynamic. Whereas splints, people can say they're a bit cumbersome, gives you limited footwear options, and they can find it a bit heavy and things as well. But yeah, lots of pros and cons. But hopefully, if you're talking to your physios or your orthotists, they're listening to what your priorities are as well. So it should be collaborative. It's not a prescription per se. So other aids to minimise your risk of falls, which I'm sure you are all aware of and been through before, but considering what walking aids are right for you, and it may be that you don't need anything indoors because you've got everything set up, but outdoors you might need walking poles just to help with your balance, or sticks, crutches, a frame. You may need to decide when to compromise to use a wheelchair, which environments, or invest in using a scooter as well. And then at home, considering your environment, whether there's any spots that you might need rails, and equipment like perching stools can help conserve energy or make it a bit safer when doing stuff in the kitchen or in the bathroom. Yeah, but hopefully you can all kind of have these kind of assessments with your physios and OTs more locally, and can give you advice that's tailored to you. But people do tend to have a selection of things. But what I would say is, if it isn't working, get rid of it. Like, if it's, otherwise it's clutter, and you don't need it. Now, with regards to kind of managing your risk of falls from an exercise point of view, there is, again, no specific HSP research, but there is lots of research and evidence in older populations that Tai Chi actually is really beneficial for reducing risk of falls. So that's kind of slow, controlled movements, balance exercises. So, I would extrapolate that information to other neurological conditions and other health conditions. Strength and balance training is really important. I know Geeta talked all about exercise last time, so we're not going to kind of rehash that. But any exercise that you do to help with falls needs to be high dose. So kind of the research is saying kind of over 50 hours over a 6-month period is what they showed actually reduce your risk of falls. But for people with chronic conditions, exercise needs to be just part of your general self-management, I think, and long-term management, whatever that be. And it usually needs to be something you enjoy and keeps you motivated. And also stretches for people with HSP as well, maintaining that mobility as well, particularly in your calves as well. I just mentioned briefly bone health as well. So it's worth kind of knowing that your optimum bone density is in your mid-20s and 30s, and your bone is continually being replaced. That material is being renewed, regenerated. But after that optimum time in your 20s and 30s, it's that process is slower. So if you're not having an optimum diet with your calcium and vitamin D and doing weight bearing exercises, then your risk of osteopenia, so kind of your bone density becoming lower, and therefore your risk of fracturing becoming higher as well. So you do need to pay attention to that for your long-term health going forwards, to reduce the risk of hurting yourself. So how to fall? So, for some people, they come to our clinic and they say, I fall once a week, every couple of days, every day even. And people need to kind of, if that is something that is just part of their condition and they're going to fall, it is worth considering, again, looking at your environment, about how you fall, where you fall, when does it happen, and think about all those risk factors we've talked about and which things can you change to influence that. So if you know it's always somewhere, you want to make sure that you're not going to hit something like a marble, I don't know, kitchen island or something that's going to make it a really catastrophic fall. So kind of try and plan for where your softer landings might be. You need to relax, as weird as that sounds. So the more tense you are and the more you try to save yourself, you more risk of injuries. And it's really important to think about protecting your head as well. So if you can have a moment to think, like to tuck your chin and make sure that your head is not the thing that's going to get hit. Also, it's really important to think about, people often say, oh, I put my hand out because I didn't want to fall on my bottom, and then they break their wrist, they fracture their wrist. But actually, you kind of want to fall on the meat, if you like, the soft, fleshy bit. So actually falling on your bottom might be better than falling on a vulnerable wrist. So actually, you might want to put your elbow out rather than your wrist, because it's quite common to fracture those wrists. And actually your bottom is kind of designed to sit on. So if you're going to kind of fall or lower yourself to the ground, eventually if you get it on your bottom, then that's better than fracturing a bone. If you can, just kind of roll into it as well. So it's quite interesting that there's a lot of sports that they teach you how to fall. So if you look at things like judo and stuff like that, they actually teach there's a proper way to fall. So a lot of that has been extrapolated to elderly fallers and things. So there's some really interesting kind of YouTube videos, or you could talk to your physio to run through what would be the best way to learn how to fall. So you can actually kind of think in that in more detail if that's something you do. I mean, I've got some CP patients, and they have a real technique because they fall all of the time, and that includes kind of doing some rolls and things like that. So they kind of develop a bit of technique over time. But from your safety point of view, make sure that you've got your mobile phone or a personal alarm to get help. So if you're going to depend on your mobile phone, you need to make sure it's with you all the time. So it's either got to be on a lanyard or a bum bag or something. If not, it might be worth investing in a personal alarm, which often is on a wrist, or again, you can have it on a necklace, and it's kind of a red button, and you should be able, you can buy them, I think now even from Boots, and they link up to a call center. And if you're in trouble, you can activate that and talk to someone and get help. And that may be calling a relative or an ambulance, depending on the situation. Make sure someone's got the keys to your house if you live alone in particular, or that you have a key safe and people know the number to your key. And you might want to think about having blankets or pillows around if you think, you know, this is particularly for the elderly, if they might think they have a long lie on the floor, just to make sure they can be comfortable while they wait for help and things like that. So getting off the floor is actually a really important skill to practice, and I would urge you to go through that or make that a goal if you're seeing a physiotherapist, or have done or are going to in the future, so that you actually know what is the technique that works best for you. And it will vary a little bit depending on your level of mobility. So then take that skill away and practice it at home, and work out what works for you in your environment. And I did put this link in here. I don't know if it will work, let's hope. But it was just a nice, there's loads of, we call it backward chaining. It's just different ways of getting off the floor. But essentially, when you practice backward chaining, you practice going from the chair down to the floor, back up to the chair. So you kind of do the last bits first, if you like. But this lady's showing one technique, and it involves rolling onto your side, pushing up onto the side, and then she's going to kind of bum shuffle. She's pulled down a cushion to get onto her bottom, and from there she's kind of going to use it as a step to push herself up into the chair again. Another way of doing it, which is more common as well, is the same thing, rolling to your side, and go on your hands and knees if you can. So if you can crawl, and you can get your hands onto a chair, and then kind of twist. Either you stand, or you can kind of twist and shuffle your bottom into the chair and sit down as well. So hopefully there are some ideas that you might be able to use, but I would practice it. Make sure you know you can do it. It's going the wrong way. So what I would kind of encourage you guys to do is, with this information, just think about your own risk factors, because it will be very personal, and think about which things you can influence and which things you can change and which things you might need help for. So kind of tiny little 5% here, 5% there, 1% there can make a really big difference to the overall picture. But I would seek professional support if you are falling a lot. So there are falls clinics, and like I said right at the beginning, there are not many specific HSP ones, but there are falls clinics and falls practitioners around. Or it may be that, you know, your needs can be met by the community occupational therapists or physiotherapists. So definitely worth looking into that if that is a problem for you. Lots of information on the CSP. I've just put CSP, which is the Chartered Society of Physiotherapy. Again, that's general falls information, not HSP specific.